Hi, this is Atif Zahir, and today I'm going to be discussing an article from January 2018 Radiology by the title of Evidence Supporting for LI-RADS Major Features for CT and MR Imaging-Based Diagnosis of HCC. This is a nice article by Tang et al. That discusses the quality of evidence of supporting each LI-RADS major feature for diagnosis of HCC, as well as of the LI-RADS imaging features suggesting malignancies other than HCC. Now, the first feature to talk about is the arterial phase hyperenhancement. Now, to qualify, the enhancing portion must have higher intensity on MRI or attenuation on CT than background liver in the arterial phase. Now, the arterial phase hyperenhancement must be distinguished from the rim arterial phase hyperenhancement, which is a subtype of arterial phase hyperenhancement in which the arterial phase enhancement is most pronounced in the periphery. Now, unlike arterial phase hyperenhancement, which is a major feature of HCC, the rim arterial enhancement suggests malignancy other than HCC. Now, this could be seen in the lesion as a whole, hyperenhancement compared to the background liver parenchyma, or just part of the lesion hyperenhancing compared to the rest of the lesion and the background liver parenchyma. Here's an example of a 53-year-old man with HCC. So you can see a hypointensity 1 lesion in the liver, which shows hyperenhancement on the arterial phase and shows washout on the portal venous and delayed phases. Now, the diagnostic performance of arterial phase hyperenhancement, the studies have showed that arterial phase hyperenhancement is more sensitive than other dynamic contrast enhancement features such as washout or capsular appearance for the diagnosis of a malignant HCC, with the reported sensitivities ranging from 65 to 96%. Now, compared with its sensitivity for malignant HCC, the hyperenhancement has low sensitivity for early or well-differentiated HCCs due to the presence of incomplete neovascularization, and for poorly differentiated HCC due to the conversion to the glycolytic metabolism and shutdown of angiogenesis. Now, the arterial phase hyperenhancement lacks specificity for HCC. Other lesions such as hemangiomas, dysplastic nodules, and non-HCC's malignant lesions such as intrahepatic cholangiocarcinoma can also have this feature. And for this reason, the positive predictive value of arterial phase hyperenhancement is not sufficient for it to be the sole diagnostic imaging criteria for HCC. So you have to combine this with washout, which increases the specificity for the diagnosis of HCC. So the recommendations are that the arterial phase hyperenhancement is a sensitive imaging feature for malignant HCC in the at-risk patients, and in combination with washout provides really high specificity. Now, it should be a major criteria for the diagnosis of HCC, which is shown by the moderate evidence, but remains a strong recommendation. Now, the next feature to look at is the diameter of the lesion. So how do you calculate the diameter? Well, you want to measure it from the outer edge to the outer edge, as shown here. You want to include the capsule. You want to measure the longest dimension, and the entire lesion should be measured. You want to exclude the perfusion alterations, so just the lesion, not the perfusion. Increasing size suggests more aggressive behavior. Pre-malignant nodules rarely grow larger than about 15 millimeters. The LI-RADS recommends that the diameter measurement should be done in non-arterial phases whenever possible due to extensive variability in the timing of the arterial phase. So the recommendations are that the larger diameter is a predictor of malignancy and facilitates non-invasive imaging diagnosis of HCC in at-risk patients. The threshold is between 10 and 20, and it should be used as a major criteria for size. The diameter should be measured on the sequence on the phase in which the margins are most sharply demarcated. And there's no anatomic distortion. It should not be measured in the arterial phase if the margins are clearly visualized in another phase or sequence. So try to not measure it in the arterial phase. Now the next feature is the washout appearance. Notice that the washout is in quotes, and that's because LI-RADS advocates the terms washout appearance or washout with quotes over washout without quotes, because it's a subjective perception which may be an optical illusion rather than representing a true washout. Um, the quantitative assessment of washout has shown better sensitivity than qualitative assessment, but this improvement is obtained at the expense of a higher number of false positive findings. A study suggests that lesion to liver signal intensity ratio of 0.88 on MR imaging correlates most strongly with the reader's visual interpretation of washout. Now you have to remember that this washout has to be measured on the portal venous phase and not on the delayed phase, because the rapid uptake of the agent by background hepatocytes is substantially enhanced in the delayed phases. So as a result, the relative hypointensity of the lesion in this phase may reflect just rapid drainage of the contrast material or lack of functional hepatocytes relative to background liver, or a combination of the two. So the LI-RADS recommends highly the washout as a strong predictor and major criteria for HCC. This is an example of a case where you have a lesion which is almost isodense to the liver on the pre-contrast phase on CT. Does not show arterial enhancement, but does show washout, which becomes most pronounced on the delayed phase, but you can start appreciating that on the portal venous phase. Now, the diagnostic performance of washout appearance as a standalone feature. Studies show that the diagnostic performance of washout alone with that of combined washout and arterial phase hyperenhancement found that the washout alone has lower specificity and positive predictive values. Compare that to the diagnostic performance of the arterial phase hyperenhancement and washout appearance, that increases your specificity and the positive predictive values. So the recommendation is that washout appearance in combination with arterial phase hyperenhancement provides high positive predictive value for HCC in the at-risk patients, and the washout should be included as a major imaging criteria for the diagnosis of HCC. Now the next feature is capsular appearance. Notice again that the capsule is in quotes, and that is because the rim enhancement does not always represent a true tumor capsule and may instead represent a pseudocapsule. And this distinction between true and pseudocapsule cannot be made definitively on imaging, and it's only made on pathology. That's why LI-RADS favors the term quote-unquote capsule. Now, the histologic feature of progressed HCC with expansile growth capsule formation is rare in early, very well differentiated HCC and an infiltrative, poorly differentiated HCC, and it does not occur with intrahepatic cholangiocarcinoma. Now, the capsule derives its blood supply from the portal venous system, which may in part account for the delayed capsular enhancement on portal venous phase imaging. You want to see smooth, uniform, sharp borders around most of the lesion, and then it's really enhancing on the portal venous delayed phases as opposed to arterial phase. Here's a nice case where you have a 54-year-old man with HCC, and you can see a hypointense lesion on the left lobe of the liver on the pre-contrast images, and shows hyper enhancement on the arterial phase. Now then it shows this washout and a capsule on the portal venous phase, which becomes more pronounced on the delayed phase imaging. Now, in terms of the diagnostic performance of the capsular appearance, you can see that the sensitivity is low, but the specificity is really high, and actually it's as a standalone feature or in combination with size may be a better predictor of HCC than washout appearance alone. So the recommendations are that based on our limited evidence, the capsule appearance provides high specificity for HCC, and it's a recognized feature for HCC. So it should be a major criteria for the diagnosis of HCC. Feature is threshold growth. So you can have three of the following scenarios. You can either have an increase in diameter of a mass compared with this baseline by a minimum of 5 millimeters and by at least 50% increase in diameter within less than 6 months, or you can have 100% growth in the size if more than 6 months time frame is being looked at. If you have a new lesion, then it has to be greater than 10 millimeter in less than 24 months follow-up. Here we can summarize data from retrospective studies. The data suggests that the median tumor volume doubling time in untreated primary HCC is 178 days, while the median tumor volume doubling time of recurrent HCCs after local regional treatment is 82 days. So the threshold growth should be a major criteria for diagnosis of HCC, and it is a strong recommendation despite the low quality of evidence. Finally, they briefly talked about imaging features suggesting other malignancies. Now, you can have atypical HCCs that can have features such as diffusion restriction, growth, signal intensity, different than background liver, but you have to start thinking of intrahepatic cholangiocarcinoma. If you see rim arterial phase hyperenhancement, if you see delayed central enhancement, if you see target appearance at the hepatobiliary phase or target appearance at DWI, and no imaging features indicating hepatocellular origin. Now, in summary, arterial phase hyperenhancement is highly sensitive feature, and then when combined with washout gives high specificity and high positive predictive value. Now, the presence of a capsule is a very specific feature. Now, the other features that suggest malignancy are the increased size and increase interval growth. Thank you very much for your attention.